Welcome to the webinar, Motivating Healthy Diet and Physical Activity. Hi, I'm Barbara Lewis, the Managing Editor for .com, an online communication skills learning system for medical schools, residency PA and NP programs, and hospitals, now that .com offers over 40 CME credits. Joining me today is Dr. Jeffrey Williams, an internist and health psychologist at the University of Rochester, where his research and practice focus on human motivation related to health behavior. He is the author of .com's Module 25, Motivating a Healthy Diet and Physical Activity. Welcome, Dr. Williams.
Yeah, thank you. It's a pleasure to be here.
Thank you. So let's start off by telling us a little bit about your background.
Well, I work here. I was 25 years as an academic primary care physician, and I've worked in the last 10 years more as a preventive cardiologist. But I have some training in internal medicine, of course, and I have a PhD in health psychology. And my work has really been trying to apply a theory of motivation into our clinical practice to motivate people around difficult to change health behaviors. And actually it's been applied into looking at motivation in clinicians too, and how we learn to change our behaviors. So that's, I focus a lot on lipids, weight loss, diabetes prevention, smoking cessation, and diabetes prevention.
Thank you so much for being here. We certainly appreciate it. So the webinar is going to last about 30 minutes. A recording and a PowerPoint will be available on the website shortly, the .com website. And if you have any questions, you can type them into the chat box located on the panel, and we'll try to answer them. But if we don't get a chance to answer your question during the webinar, we will respond afterwards. So let's get started.
To start with looking at the problem, or sort of the scope of the problem that we face here in the United States, and really a growing problem around the world, is we have over 300,000 premature deaths in the United States are attributable to unhealthy diet and physical inactivity. And yet in physician counseling, particularly in primary care, where we do brief interventions, less than about 30% of patients receive lifestyle counseling in these areas. So we've been working about two aspects of looking at nutrition and physical activity, if you will. Balancing energy intake, so that is trying to work with people around who are overweight or obese and trying to lose weight, and that has to do with shifting the calorie balance. And then there's also about motivating just healthy dietary patterns as well as physical activity patterns, even if people are of normal weight or if they're just not able to lose more weight. The problem that we've had has been increasing since certainly for some time, but originates sort of exploding into our environment around in the early 1990s, when portion distortion started to occur, and our jobs led us to become more and more sedentary, so we're not burning the calories that we were doing before. And a typical person will, if they walk at a modest rate, not a fast rate, might burn 250 to 300 calories in 60 minutes. That's about what the calories they get in a candy bar. I was thinking about walking a mile. People generally burn about 100 calories. That's the equivalent of 2 Oreo cookies, or 150 calories is in a typical alcoholic drink if it doesn't have a lot of added calories, sugar, sweeteners, and so forth in it. It's expected now, since the year 2000, that we're going to have more than a third of people born after that year after, will get type 2 diabetes in their lifetime, in large part because of this reduction in burning calories and the increase in consumption and literally the calorie densities of the foods that people have available to them. The other Part of this is that people have very individual basal metabolic rates, and after about 20, we see those start to reduce. So between 20 and 60, people lose burning about 100 calories per day per decade. Between 20 and 60, that means that if they didn't decrease their calorie intake or increase their walking by a mile, they would per day, they would each decade, they would start to gain weight. And so currently we're seeing 60%, a little bit more than 60% are overweight or obese. 40% are sedentary, really getting less than 30 minutes of moderate level physical activity, walking 5 days a week. And only about 15% get enough physical activity to maintain health. Our jobs are more sedentary, and so we're not using energy at work. That's not always the case. So of course you want to find that out from your history with your patients, with what they're doing. And maintaining physical health, it actually occurs with less physical activity than it takes to lose weight. Losing weight is one of the hardest things, and then once you lose weight, maintaining it may require additional increase of about 20% of our physical activity to be able to maintain weight loss long-term over about a 30-pound amount. Once individuals become overweight or obese, we really don't do well at identifying or estimating the calories we take in. We tend to underestimate that by over 40%. And we overestimate the calories we expend by about 50%. So one of the strategies is to call their attention and really have them take some time to try to figure out some of the calories that the amount of calories they're taking in 2 or 3 days to get typical days to see what that's like. And of course, we have now MyFitnessPal and Fitbits that can help with caloric expenditure, and they can help estimate calories through computer programs. The basis of all of these kind of changes, though, that we facilitate through our practice comes through the core counseling principles, building on a positive relationship. This enhances motivation. So we want to start that by soliciting and respecting patients, soliciting patients' history and being respectful about advice that we give about diet and activity. We want to use the strength of the communication strategies that we have to enhance relationship. This is one of the core motivators for human beings, and I think underestimated in the physician-patient relationship is how much patients really appreciate when they have a positive relationship around areas that they're very sensitive about, such as their weight and some of their health behaviors. What we're going to talk about is how to apply this in a brief format, such as recommended by the U.S. Preventive Services Task Force, so that might give you 5 to 10 minutes of counseling for diet and physical activity. One of the key things about this, though, to change diet, lose weight, we really need multiple visits. So the way that we enhance the impact of the counseling that we give is by offering additional visits over time to check to see how they're doing and providing feedback and support for them as they work through this. People who you're talking with in your practice, I remember this very well from my own practice, but we know this from elsewhere. The fact that you may mention it several times, that their blood pressure may be going up or that their weight may be going up and that you would recommend change. They may need to hear that several times and feel a positive sense of support and relationship with you before they even begin to make an effort to change. And of course, well studied is that most times when we make behavior changes, the average may be that we need 8 to 10 times to start to change our diet, to stop smoking, reduce our alcohol intake, integrate a new physical activity pattern. Even physicians have been studied and shown to need several attempts to incorporate a new counseling pattern or a new treatment into their practice effectively before they really own it and feel it as their own.
So Jeff,
Office
we've had, I'm
yeah.
sorry, I was just going to say we had a question come in already.
Okay,
and
great.
Someone wants your opinion of intermittent fasting.
Intermittent fasting. So there's starting to be some studies about that where the program that I'm familiar with is a 5-2 program where people reduce their calories pretty substantially on 2 of the 5 days of the week. And I think that we probably don't have good long-term data on this yet, but in general, we don't like extended periods of time where people are getting less than 1,000 calories per day. They tend to get constipated, they don't feel well, they lose energy and so forth, and they may get into a variety of metabolic problems. So, but I see positive reviews about this kind of approach, but I haven't seen comprehensive or multiple studies that have shown that this is effective over a period of time. We do want to focus on office counseling. We think that patients really like to be able to engage around this topic, even if many clinicians may be uncomfortable with that. So I'm going to shift over now to motivation, and in its definition, and its distinction to behavioral theory, motivation pays attention to human energy or psychological energy. This comes from empathic relationships with others. It comes from feeling positively supported and involved with others, and it also comes from people feeling that they're giving and having a positive relationship themselves by things that they give to others through relationship. This is bidirectional, and both sides can be very energizing for people. High levels of patient autonomy is where people start to feel that they're owning and taking responsibility for the behaviors they're undertaking for themselves rather than for the clinician or for their spouse or for someone else. And high levels of perceived efficacy or competence. These are all energizing, feeling more able to achieve the outcome that they're seeking. Motivation, though, isn't complete unless it has a direction. And so we need to be clear about the health goals that can be achieved and to negotiate those with patients. Very frequently when I meet with somebody who wants to lose weight, they want to lose 40, 50, or 60 pounds. My goal for them, where I think that they're going to achieve health, and we might expect to see 50% of a population be able to maintain that weight loss, is probably closer to 5 to 10% body weight loss, which is going to be more 15 to 25 pounds for most individuals. So we want to clarify those goals and be sure that patients understand that it's likely that the health goal is going to be achieved well before they may get to their personal satisfaction of the total amount of weight they want to lose. So to be effective, counseling must include enhancement of both the energization. We need to look for what is motivating someone, what is the quality of their motivation, and also the direction that and the goal that they're trying to achieve. We use start from the framework that we feel that all human beings have psychological needs. These are psychological nutriments, if you will, that are essential for ongoing psychological growth, integrity, and well-being. And it means that if these are not supported, things go wrong. People suffer with depression, anxiety. They may abuse substances. We find correlations with that. We see increase in suicidality when people have low satisfaction of these needs over time. So this can be used as a developmental and as well as a health behavior change model or theory. Intrinsic motivation is important because we assume that people are motivated for their own growth and well-being. We don't have to add that. We want to bring that out and enhance that. And we can do that through engaging them around what is interesting to them, about things that they may want to learn about appropriate levels of challenge where it's not too easy but not too hard. So it's a natural tendency for us to want to gain mastery of our inner and outer worlds, and that may be people may feel very positively challenged about integrating regular physical activity or changing their diet in a way in a difficult and complex lives that we all live. So we do these things out of a sense, with a sense that people are going to build on motivation that they have, and we want to try to enhance that. 3 sources that we can look for energy are these needs. The need for autonomy is the need to feel one is regulating one's own behaviors and experiences and actions, to feel fully volitional in what one's doing. Competence is to need to feel efficacy and mastery, to be able to achieve, say, the goal of weight loss or some levels of physical activity. Physical activity for athletes is really all about this mastery and finding the optimal level that people work at. But what we want to do is have people feel that they can master getting up off the couch and being able to get out for 30 to 50 minutes of walking on a regular basis. And then relatedness is the need to feel connected to and cared for by others. Autonomy support, we want to elicit patients' perspectives, necessarily before making recommendations. What do you see the issue is your weight? How much weight do you want to lose? Acknowledge patient affect very frequently. Sometimes they've been trying many times and feel unsuccessful with this. I'll see a lot of affect when interviewing people about weight or about trying to prevent a disease. And be empathic, both verbally and non-verbally. Discuss the disorders and illnesses caused by poor diet and activity. Would it be worthwhile for you to prevent diabetes? We know that certain levels of physical activity can prevent cancers or may reduce recurrence of certain cancers and heart disease. Discuss the risks and benefits of no treatment. I think we frequently leave off what happens if nothing is done, what is likely to be expected, and risks and benefits of treatments that you want to outline. Identify and agree on the health goals that the patient is willing to pursue, and this becomes real important in that 5 A's model that we're going to try a couple of different versions of. So identify effective options for change, discuss effective lifestyle change options, perhaps gradually increasing by 10 or 15 minutes a day, going for a walk, or setting the computer to get up from work every 2 hours so that you're not sedentary over that period of time, are nice ways to add physical activity to your day. Be sure that people understand the full menu of options, including bariatric surgery, which now can lead to remission of diabetes, if that's type 2 diabetes, if that's something that someone has had. Or we can use adjunctive medications for obesity in addition to altering the calorie balance. Elicit patients' understanding of options and perspectives about their options for what they may want to try. Think of this as when people have multiple things that they can choose from that they know may be effective, it's very motivating for them. It tends to increase their sense of autonomy and ownership on this. And provide recommendations clearly. I would recommend you lose 15 pounds. Your prediabetes is likely to improve, and we may be able to prevent or delay your going on to get diabetes. Would be the rationale for change. Support their initiatives, and I think this is a critical thing that I always go over with people in interviews, is you're really trying to find some element of success. When somebody has tried for the first time to initiate a change, even if it didn't go well, you want to reframe that into a short success and find out what it was like when they were doing that. We should expect that most people get derailed from the initiations that we have. But it's very helpful. I call this sort of nascent autonomy, where people are first trying to take an initiative on something. And the goal for us, or the task for us, is to find those successes, those brief successes they have, and amplify them back to them and see if they're willing to try again if they've not been successful. And try to resist patients to persuade or control people around the decisions. You really want to invite them in to look at the problem with them. We look at the 5 A's. This is the U.S. Preventive Services Task Force, so we'll apply this in a couple of different places or ways. To assess the background information regarding risk behaviors and patients' knowledge related to physical activity and diet. Provide advice that's personalized to the patient's situation. if you begin physical activity, we know that there's about a 20% reduction in your risk for heart attack or stroke going forward, might be such a statement. But something that you feel confident in and that you feel comfortable in delivering. Establish whether patients are willing to change. And this is really the middle A here was added around the year 2000 and is really about respect and supporting autonomy. So it's about their willingness to engage in this, explore with that. This is going to set collaborative goals and see what they're ready to take their first steps with. Establish a change date and then get into a specific change plan when they're willing to commit to that. Generally, you want to focus on this happening within the next week or two, but it can go out even to a month, depending on what their schedule is and so forth. Beyond a month, we think that their focus and plans for change tend to fall off. So I would tend to try to reschedule them shortly before they're getting into that. But you can start to outline a plan with them, build skills, support motivation, give them information about this. If there are medications that you're going to be involved with, you might discuss them. I typically, around weight loss, don't start with medications, but offer them over time if people are not successful in initiating their weight loss. And really look for those short successes. Arrange the follow-up is critical here for weight loss. For physicians in primary care, we can actually bill for 14 visits in a 6-month period of time, and even weekly for the first month. So there's a real special time at that initiation of wanting to, if we can, see people more frequently, or perhaps just a follow-up phone call if you can't see them on any kind of regular basis. Or you might establish someone else in your practice who might, one of the nurses who wants to pick this up or do this, or if you have a registered dietitian, you can have them meet with patients on a more regular basis with you seeing them at established follow-up times. The WAVE assessment is one of the ways to look at this. This was developed at Harvard by a physician named Dr. Black. He passed away recently. But first assessment, of course, is the patient under or overweight. That's your perspective, but you also want to get the patient side of that they perceive themselves as under or overweight. Does the person get enough physical activity to optimize health, or to at least avoid certain diseases? So we look at that as 30 minutes of moderate level physical activity. Walking at a good pace where you just may not be able to quite finish a sentence or get a light sweat. And to manage weight. Actually, eventually, we want them to start with that over the first 6 months while they're reducing calories. But the long-term plan about managing weight means they're probably going to have to increase their physical activity up to about 60 minutes of walking if they're going to be able to translate that into maintenance. A variety of foods, that's going to be a healthy eating pattern. We'll talk about those in a minute. And of course, is the patient eating too much? Are you seeing an increase in weight? So there is an assessment that goes with the REAP, which is an interesting questionnaire for people to go through. We're not going to go through that, but you could look that up if you want. I frequently had people fill this out, and then I discuss if there was 1 or 2 areas in the 15 or so areas that were asked about with their lifestyle, if they wanted to focus on 1 or 2 and plan about those. Next. You want to continue to support patients' autonomy around information giving. Use motivational language as you offer advice and new information, and to begin the assist process. As you move on into that, you want to figure out the plan that you're going to move forward and with, and the frequency at which you're going to see patients. I see people intensively around this, so but not everybody's expecting that. So I'm negotiating, is this something that you're willing to do, to come in to see me on a regular basis so that we see how this goes. Calibrating the patient's motivation and confidence. You can do that with a couple of brief scales, 1 to 10 scales. We'll go over those. It shows your interest in how they're feeling about things. You want to avoid giving orders. And ask patients to tell you about how they're doing with their own motivation, about the importance of this and the confidence they have. If patients have a stable body mass index, you want to ask them if they'd like to discuss current nutrition and activity guidelines. They indicate an interest. You can talk about their past success with their BMI and make an advice statement about be sure they continue their activity. Get their perspective on how they're being able to do that, compliment them on it if they've been able to sustain a change over time. This is difficult to do. And whether they would like advice about some specific strategies. Balance calories with physical activity to manage weight. The food data, there's been some just superb summary articles about the importance of types of nutrition patterns and foods that people eat. Fruits and vegetables being our healthiest, up to 8 servings, half cup each. Reduces cancers, reduces cardiovascular disease. Nuts, 25% fewer lung cancers, for instance, with an ounce of nuts per day. Reductions in heart attacks and strokes, fat-free and low-fat dairy products, and seafood. These kind of patterns, if you want to look at them, this is reviewed in the Journal of the American College of Cardiology. What I like about this particular table is it tells us where the strength of evidence is. You'll see that one of the popular trends has been to add coconut oil, but in fact this raises LDL cholesterol. It is not recommended. It's recommended to be avoided. Whereas olive oil, of course, and palm oil have randomized controlled trial outcomes associated with them. I should say that sunflower oil in moderation, olive oil in moderation, canola oil in moderation, if you will, and nuts all in moderation have been shown to be associated with improved cardiovascular outcomes. The fruits and vegetables have been strongly looked at, and avoiding the southern diet, which is rich in organ meats, fats, added fats, and so forth, which can increase cardiovascular events by 50% or more in about a 6-year period of time in one study. Another very interesting motivational wrinkle on looking at diet patterns and diet counseling is actually it may be easier for people to establish a healthy pattern, such as the DASH diet, which is called the U.S. Healthy Style Eating Pattern, emphasizes low salt, but all those foods that we talked about before, or Mediterranean style eating pattern, or vegetarian eating pattern are all recommended by the dietary guidelines for 2015. And you can organize that by looking at myplate.gov. Many of you may have seen this, but it's about half your plate is then. And it's important that you look at the diameter of the plate, that it's 9 inches here. So fruits and vegetables occupy about half of it. Whole grains, oat-based grains, particularly good at lowering cholesterol, but all whole grains provide additional fiber, which is very healthy. And then about a quarter of the plate are only about 6 ounces of lean meats, if you're having that, or 6 ounces of a protein source. Build a healthy plate so that you enjoy your food. You want to check back with people. This can't feel like these people are sentenced to eating foods that they don't like. It's really about an experiment to see what you can sustain. About half your grains being whole grains. Find some foods that you, sometimes I just ask people to count their calories and find 300 calories of their own choice that they don't want to eat, or take their usual serving size and reduce it by 1/3, and we should start to see some reduction in weight if they increase their walking by about 30 minutes. An 8-week goal cycle for anyone 18 years or older. You want to gradually increase physical activity, a goal to get to at least 30 minutes 5 days a week, and to try to get that for 6 to 8 weeks for the initial period of time. If they're counting steps, 8,500 to 10,000 steps per day would be a very positive goal. And healthy eating, choose one of the healthy eating categories to try to incorporate each week, and try to see how many you can add up over 6 weeks, and then check back with them to see how they're doing. Ask permission to discuss weight, assess their willingness. May represent a big change for them if they're not asking you about it themselves. Advise that this can shake a lot of things up, but it may be worthwhile for them if they, you particularly want to find out if they feel hopeless about this, if they've given up, sort of to see if there's ways that you might be able to support them in this. And make an activity recommendation, nutrition recommendation. Typically we try to do both. We try to create about 500 to 700 calorie per day difference between what they're eating and what they burn. And it's easiest if they increase their walking by a half an hour and decrease their calories by about 300, and you'll hit that spot for about a ½ pound to a pound weight loss per week. And then ask them about the quality of their foods. Patients with high blood pressure or other cardiometabolic problems can sustain healthy lifestyle. I think that's sort of a myth in practice that can't happen. Think about the DASH diet, but this has been demonstrated in the both the diabetes prevention program and the Look Ahead program, where people really sustained lifestyle changes over a 12-year period of time with improvements in cardiometabolic health indicators and with weight loss. They don't keep the weight at the same level, but they can sustain it over time with support. Importance for calibrating, assess their conviction on these 10-point scales. I'm not at all convinced that you want to do this, to totally convinced that you're going to go do this, and assessing their confidence. How able do you feel you're going to be able to do this? These fit well with the autonomy and the competence needs in self-determination theory, and fit also into motivational interviewing. And relates to their readiness to change, and allows you to advise, to tailor your advice statements and your assist steps based on what you're hearing. And I'll finish with that.
Thank you so much. That was so interesting and such an important topic, and I feel like we rushed through this and we could talk another hour about this, but thank you very much, and thank you to everyone who has joined us. You can get more information on our .com module 25. And also, because you participated in this webinar, you can take advantage of a free 30-day trial subscription to .com at .com.org. Just put in WebJUN17. No credit card is required. And a recording of the webinar and the PowerPoint will be on our website very shortly. So thank you, Dr. Williams, and thank you to everyone for joining us today.
Have a great day. Take a walk.
Thank you. I will. Thank you. I'm motivated.
Take care. Bye.